Uh, Good evening, everyone. Good evening, Dr. Siddiqui. A very warm and hearty welcome to your webinar today. Mr. Bhardwaj, very good evening to you as well. With your permission, I'd like to start today. But before we start with the webinar, I'd like to give a small introduction to Dr. AreenaSiddiqui. Dr. Siddiqui has been a medical professional for the last 17 years. And, when I went through her CV, it was very difficult for me to put together a 1 minute or a 2 minute introduction to Dr. Siddiqui. She comes with 17 years of experience and has worked in several roles across the country. After completing her MD in 2011, if I'm not wrong, from MS Ramaya in Bangalore, she has been at the forefront of several activities in Lucknow. She is based out of Lucknow and is currently the head of consultant and head microbiology of the infection control and molecular pathology at the Sahara Hospital in Lucknow. She has over 25 publications to her name, a lot of trainings, a lot of awards in her name. And I don't think 1 or 2 minutes would do that justice. But when she said yes to coming and speaking on the subject of scrub typhus, which is, as I call it, a hidden epidemic in this country, we are very thankful to you, ma'am. And without further ado, I'd like to hand over the forum to you, right? And please take us forward through this approach to scrub typhus in the healthcare setup. Over to you, ma'am.
Good evening, everybody. And thank you for the introduction. Thank you so much. And the topic, I think the scrub typhus itself, it's very important because it's a re-emerging disease, and even the government setups, they have started taking this disease seriously. And before scrub typhus, also I would like to discuss about the fever, because the most common symptom which a patient presents when he's suffering from scrub typhus infection is fever. So we'll start with the fever, and then I will confine myself or focus myself more towards the scrub typhus diagnosis and treatment. So next slide, please. Okay, so I'll start my webinar with a very famous saying by William Osler. Humanity has but 3 great enemies: fever, famine, and war. Of these, by far the greatest, by far the most terrible is fever. So we in this, it is said that fever is the most terrible. And the fever, if the fever persists for more than 3 weeks, that is 21 days, then it is an enigma to the clinician. And the diagnosis and management of this condition, it becomes very difficult. And then we say that it is a combination of art and science, how we manage it and how we put our science into it in the management and the treatment and the diagnosis to treat the patient. Next. So classification of fever. So we have a person who is suffering from fever more than 3 weeks or less than 3 weeks. So we have divided it into fever of unknown origin, where the patient is suffering for fever undiagnosed for more than 21 days. But if it is less than 21 days, then we say that it is acute undifferentiated febrile illness. So if acute undifferentiated febrile illness, when the patient admits to the hospital, then if it is diagnosed, it's well and good. But many times it is not diagnosed, and we say that it is undiagnosed undifferentiated fever. Again, it is resolved maybe by another week. But when it is not resolved in next week, then we say that it is FUO, that is fever of unknown origin, when it is more than 21 days. So this is how we are going to classify the fever. When we get indication who is suffering from fever, we take the history of the fever, like since when the patient was having fever. So this is how we are going to classify it. Next. So definition, I'll start with the definition of acute undifferentiated febrile illness, which is more related to our topic. How it is characterized. It is characterized by fever of less than 2 weeks duration, with or without. It's very important with with or without, but initially it is without any organ specific symptoms at the onset. It might begin with headache, chills, myalgia, And acute undifferentiated febrile illness, it can range from mild to self-limiting disease, maybe later on progressive life-threatening illness. And specific organs may be involved later. A mortality rate of 12% has been reported in severely hospitalized patients in tropical region, and this excerpt I have taken from British Medical Journal, which was published in 2018. Next. So what are the challenges in diagnosing? So let's discuss. First, I have told that there are no specific, that is non-specificity of signs and symptoms, very vague symptoms, when we will not be able to differentiate like where to fit in the diagnosis of the patient who is suffering from fever. Then lack of availability of accurate diagnostics. So we all know, first of all, the signs and symptoms, they are very vague. Secondly, the treating consultant, the differential diagnosis, what all he should keep in mind when he is dealing with a case of fever. Then third, very important is whatever the physician, the consultant is thinking, whatever he has in mind as DDs, whether he is able to rule out whether the diagnostic facilities are available or not. When the diagnostics are available, then the fourth important point is whether the facility for testing those DDs, which is there in the mind of the physician, whether it is there in the laboratory or not, whether lab is testing all the kind of disease like viruses, bacteria, protozoa, rickettsia, these are all related to, and these are all responsible for causing fever. So whether these are available in the lab or not, these are the challenges while treating a case of fever. Next. Okay, epidemiology. So this was published in 2015, and it says that according to 2014 systemic review, the proportion of undiagnosed AU, that is acute undifferentiated fever, it ranges between 8 to 80%, where 20% have the 20% of febrile cases are of malaria, 10% have rickettsia and influenza, 5 to 10% might be because of dengue, enteric fever, leptospirosis, or Japanese encephalitis. So these are the examples, these are the DDs which can be there when a patient is suffering from fever. Next. Okay, so coming to the causes, the first one, the most common is malaria. Malaria could be due to Plasmodium falciparum, Virex, Opale, malaria, and Knowlesi. Then coming to the viral disease, the arboviral infections like dengue, chikungunya, Japanese encephalitis, these are very commonly prevalent, whereas Zika, recently we have seen cases of Zika. Yellow fever, generally we see when there is any traveling history from endemic areas. So Zika and yellow fever we are not getting much, but the other three are very commonly there, and there are certain areas which are where it is endemic. So we need to keep this also in mind. Next is the enteric fever. Due to Salmonella enterica, the type Serovar typhi and paratyphi ABC, the enteric fever is also very common, and that too in the month of July, August, where we see there is increased cases of typhoid also. Coming to the next is spirochetal infections such as leptospirosis, tick-borne or louse-borne relapsing fever. Next is rickettsial infection that includes ScrubTyphus, typhus, and spotted fever. So these are the causes which should be kept in mind during the treatment of a case of fever. Next. Okay, so how do we classify when we get a case of acute febrile illness? So initially we are suspecting it as a case of malaria, and later on we come to know that no, it is some kind of respiratory infection or UTI or GI infection. But if we are not able to get the diagnosis in this, then we classify acute undifferentiated febrile illness, either malaria, and again we have certain tests, that malarial the smear test or the rapid card test, and if they both are negative, then we have to think maybe it could be a viral, that is dengue, chikungunya, Japanese encephalitis, or influenza. But the influenza, the symptoms are not very prominent, and even the fever doesn't last for more than a week. Then it could be bacteremia or bacterial infection like typhoid, that is enteric fever, or it could be due to some other bacterial infection in blood like E. coli or Staph aureus. And bacterial also, it could be zoonotic infection like in case of spirochetal, such as leptospirosis, relapsing fever, rickettsial like scrub typhus, murine typhus, spotted fevers. Then parasitic also can be responsible for fever. Like example is acute schistosomiasis and acute trypanosomiasis. Next slide. Okay, onset, duration, and pattern of fever. The pattern of fever can be disrupted by fever medications, paracetamol, but may sometimes be typical of a specific infection. Malaria, viral infections, scrub typhus, leptospirosis have an abrupt onset and can rapidly progress to complication in the first week. So scrub typhus generally present with complication in the first week. Peak in temperature every other day is seen in malaria. Sorry. Whereas fever more than 102 degrees centigrade for more than 3 days with abdominal pain, diarrhea, and constipation can suggest enteric fever. Dengue is a self-limiting cause with fever up to a week or 12 days. Fever influenza, again, it lasts for 3 days and it can be maximum for a week. Next. Okay, so now I'm confining myself to the scrub typhus. I'll be discussing about the scrub typhus, the clinical features, the presentations, diagnosis, and treatment and prevention. Next. Okay, so if a patient is having scrub typhus, how it can present to the OPD or to the ED emergency department. So it ranges from mild to fatal illness, and the symptoms usually appear within 10 to 12 days after exposure. So the exposure history is very important here, because we should know like exposure history, and also because we all know where the scrub typhus infection is related to. It is due to occupational history if the patient is a farmer, or nowadays we are seeing even in urban areas that gardening or kitchen garden, if somebody is very much doing, then even that can also lead to this kind of infection. So history of exposure, number of days are very important, and early clinical manifestations. So Ishar, it is said that it is a pathognomic, but the thing is that the occurrence ranges from 1% to 97%. So many a times we might not see the HR in a patient who is admitted to the emergency department or to ICU. But there are cases where if we look we observe the patient, the physical examination is very important. The area we should know where exactly we need to look for the HR. These are also very important. So it can be seen. So it ranges from 1% to 97%. And what it is a sore on the skin, which is with a punched out appearance, skin ulcer that becomes dark in the center at the site where the mite attached. Here one more thing which I would like to share with you, that the mite, it doesn't bite the skin area. It bites or inserts its mouth near the hair follicle. So it just inserts itself and it attaches near the hair follicle, and there we should try to find out the pustule, which we say that HR. So in 1 or 2 days, it converts to the necrotic lesion. So that is the HR formation. So it is very important. And one more thing, the intertriginous area, the trunk, then axilla. So these are the areas, the groin area. So these are the areas which are very important, which we need to observe very minutely in the patient, whether it is present or not. Then second very important sign is regional lymphadenopathy. So Ishar, with lymphadenopathy, we say that these are pathognomonic for strep typhus infection. So fever rises during the first week. So after that we see fever, and it often goes as high as 40 0.5 degrees centigrade, followed by headache and myalgia, generalized lymphadenopathy. So these are all non-specific signs and symptoms where it becomes very difficult for any treating physician to come to a diagnosis what exactly it is. Then cough is present during the first week of fever. Pneumonitis may develop during the second week. The patient might also admit with the symptoms of GI symptoms like nausea, vomiting. Then rash. Rash is very important, and many a times what I have seen in my hospital, that patient is admitted with the scrub typhus, and after 5 days or 6 days of admission, he gets a reference from the skin department because he gets a macular rash over his body. So this is very important. We should, like, if we know that the patient is of scrub typhus, then definitely the rash is to be there after 4 to 5 days of infection. So here we see that it is non-specific. It is involving the CNS. Meningoencephalitis can also be a symptom which a patient presents to the emergency department and is admitted in the neurology department. So meningoencephalitis. So these are the symptoms where it becomes very important to keep in mind that yes, it could be a patient of scrub typhus. So CNS system is involved, then CVS system, cardiovascular system is involved, where the patient presents with myocarditis, then respiratory system, where the patient is having cough initially, then he can develop pneumonia, then he can develop acute respiratory distress syndrome, maybe later on. Then in the like initially these are the symptoms. The next slide, please. So in next slide, I'll be discussing about the severe manifestations. So in severe manifestations, I discussed about the pneumonitis, the acute respiratory distress syndrome, where if we order a chest X-ray, we'll see the hazy lung fields. Then meningoencephalitis also is very important because in my setup, I have seen patients admitted in the neurology department. Then GI bleeding also very common, acute renal failure. So this is also a very important feature where the kidney is also involved. So creatinine might be increased in these patients. Patients might develop septic shock if the patient is not attended immediately. Then coagulopathy can be there, pericarditis, myocarditis I have already discussed. And also here I would like to add that this scrub typhus, this bacteria, it attacks the endothelial lining of the blood vessels. So there it leads to end organ injury. So end organ injury like liver, then the other organs which I just discussed, they lead to the development of these signs and symptoms. And in many cases, the pulse rate increases, the blood pressure drops because the patient might go into septic shock. And if the patient has CNS, then definitely the patient will land into delirium, stupor. There can be muscular twitching. Splenomegaly is very important. So many a times, if the lab reports as the scrub typhus positive, so what the consultant, they can go and they can check whether lymphadenopathy, the hepatomegaly, splenomegaly is there or not. So it could be definitely there because many a times almost 97% will miss the SHAL. So these are the other things which can be seen in the patient of scrub typhus. High fever may persist for more than 2 weeks if it is not attended. And what we see that the magical drug doxycycline, the moment they get the diagnosis, the lab reports it to be scrub typhus positive, they start doxycycline and it goes off. It's like a magic. They say the moment we start doxycycline, the patient gets treated. So this is how with therapy, defervescence usually begins within 36 hours of therapy. So this is also one like sign, yes, the patient is having scrub typhus. Next. Okay, now I discussed about the clinical presentation. Now I'll be discussing about what exactly scrub typhus is. So we can say it as bush typhus, jungle typhus, mite typhus. So there are many names which we can call it. And it is acute infectious disease, therefore, and it is being kept in acute undifferentiated febrile illness. It is caused by Orontia tsugamushi, and it is transmitted to humans by bite of certain kinds of trombiculate mites. And the larval stage, the larval stage of that mite who feed on human skin, they are responsible for the transfer of infection to humans. Generally, this is an infection of rodents and trombiculate mites. This is how it is kept and maintained in the environment. But when it interferes, when man interferes in their environment, man is an accidental host, and then he gets disease, and that is scrub typhus. And during the larval stage, these mites acquire the infection from wild rodents and other small animals. That's how it is passed to the human beings. The next question is that we all know that there are certain terms, that is mite islands. So when it is seen in mite islands, generally the area, that is the equatorial rainforest, then mountain deserts, sandy beaches, rice fields. So generally these are the areas which are designated where the scrub typhus should be present. But why? Why we are also seeing cases in our region, that is the urban area? So that is a big question. Many a times the consultant, they won't believe, no, we can't have scrub typhus in our area. No, but we have to tell them, no, sir, it can be present in the area where we are. Why? Because changes in human behavior. That is one most important reason of shifting of the mites from their mite islands to the urban civilized area. The next is the unplanned urbanization, deforestation. So when deforestation, then rapid transport leading to the displacement of vectors and rodents as well. So we see that initially it was a rural disease, but now even in urban areas, we are seeing cases of scrub typhus. Okay, then many a times the household, the females also will get scrub typhus, and the consultant, no, it can't be possible to have scrub typhus. But where? In parks, where they go for jogging, for yoga, for camping, the recreational activity, the camping is so much in. So even these are very important causes of getting scrub typhus infection in urban area. Next. Okay, these are some of the photographs. You can see a pustule in the neck where it initially starts. Next. This is the necrotic lesion at the center with the periphery. We can see the redness. So this is how it looks like. Next. This is the actual environment where bushy, grassy areas are present, equatorial rainforest, where a lot of moisture is there, and the shady areas. These are the actual areas where it grows. Next. Next is how to confirm the disease. So proper history is very important. History, occupation is very important, like from where the person is coming, who is admitted to the hospital, how frequent they are doing gardening, or if it's they are from urban or some well-to-do. Then in those cases, we should ask like kitchen gardening, whether those females or males, they involved actively in this kitchen gardening. The next is the examination. Whoever patient presents with a fever in our emergency department, we should keep the scrub typhus as a differential diagnosis, and we should look for HR in the areas where I just discussed, like the trunk, the intertriginous area, the axilla. So axilla and growing region. So these are the regions which are very important where we need to look at it. Lymphadenopathy, hepatosplenomegaly, rash generally present in the trunk, and suffused conjunctiva. So this proper history and examination is very important. Next. Okay, once we have done with the history and examination, we need to send the test to the lab. So what are the tests which can be sent to the lab. First is Whale Felix test. Second is the serology, where we see fourfold rise in change in IgG specific antibody titer by indirect IFA. And we also have ELISA, ELISA, where we see the IgM antibody, whether it is present or not, which is very diagnostic of ScrubTyphus infection. Then later on, if the laboratory is well equipped and if it has molecular equipment to diagnose the disease, we can send a PCR for the diagnosis of this disease. Next. Okay, so coming to the first one, that is Whale Felix test. Generally, Whale Felix is easy to perform at any laboratory. The only drawback is it is not very sensitive and not very specific. So this is one of the drawback, that it is not used widely. The sensitivity is less than or equal to 50%. And what the test is, this is a heterophile agglutination reaction. And in this, there are three antigens of Proteus vulgaris OX19, Proteus mirabilis OX-K antigen, and Proteus vulgaris OX2 and OX19 antigen. So Proteus vulgaris OX19, it reacts with antibodies to the typhus group, whereas mirabilis OX-K reacts with antibodies to the ScrubTyphus group. Vulgaris OX2 and OX19 antigen reacts with the antibodies to the spotted fever group. Next, I'll show the chart where we see that OX-K is specific to the ScrubTyphus, and a titer of more than 1:80 is considered significant, and if it is 1:320. If we do it again, then rise in the titer also indicates that yes, it is infection from the ScrubTyphus. If we get a single value 1:320, then it is significant, and only 180 if we get, then it is considered a probable case, and we need to follow up the case. Next. Okay, coming to the serology part. So serology, the ELISA for specific IgM antigens, and nowadays the recombinant antigens are used. They are very specific and they are very sensitive, and if we get positive, then in more than like a single test if we perform, and if it is infection of ScrubTyphus, then more than equal to 90%, the test, the performance is more than equal to 90%. And it can be elevated for over-diagnostic cutoff for 12 months. That is one thing which should be kept in mind. Then IgM ELISA, the sensitivity is 84% in acute phase and 6% overall. Then the ELISA nowadays, the antigens which are being used, the sensitivity is more than 90%, 95 to 96%. Recently, the kits which have come, they have a very good sensitivity and specificity and can be used in the laboratory. Next. In the serology, I would also like to add upon that the cards, the rapid card system, they are also there, though in many some of the like guidelines, they are not shown to be as effective, but like there are certain cards, the rapid diagnostic tests, which are equally good. Then coming to the next is PCR technology, where the HR swabs or the biopsies, they are taken and they are then used for the diagnosis, where the PCR it shows a positive result. And also the thing is, HR swabs can also, the immunohistochemical staining also can be used for the diagnosing of the ScrubTyphus from the necrotic lesions. Next. Next, please. Okay, so besides PCR, there are other diagnostic facilities, the research which are present labs with good amenities, that is loop isothermal amplification, which amplifies DNA using specially designed prime pairs, the BST DNA polymerase. Then also there are nested PCR technique. There are various literatures which say that nested PCR it can detect as early as day 3 of infection. Next. Okay, so we were limited to the diagnosis of the ScrubTyphus per se, and now the other parameters which should also be looked in the patient when we are dealing with a case of ScrubTyphus. So what we see when we order for complete blood count, we see that there is leukocytosis when it is more than 11,000. Thrombocytopenia could be there when it is less than 1.5 lakh. The SGOT-PT are raised because I discussed that there is hepatomegaly also. So because of that, there are raised SGOT and PT. Hypoalbuminemia less than 3 gram per deciliter can also be seen in blood. Hyperbilirubinemia can also be a diagnostic or can help in diagnosis. Then if we do ultrasonography, we see liver and spleen enlargement and chest X-ray as I discussed. Then when the patient develops acute respiratory distress syndrome, then there can be bilateral infiltrates which can later on lead to pleural effusion. Next. Okay, so coming to the treatment part. So once we know that it is a patient of patient with acute undifferentiated febrile illness, we have all the DDs in our mind. We have besides ScrubTyphus, like though I discussed about the ScrubTyphus, but when we admit a case of fever in the emergency department, we have to keep all the diseases in mind, and we have to send all the tests with respect to the infections which are possible, which can happen, which can be a cause of fever for AUFI, that is acute and differentiated febrile illness. And then once we have sent all the tests and we get the report, so we now get the reports and we see that yes, it is on the ScrubTyphus positive, then we start the treatment. So what is the treatment which is to be given to the patient? Next slide. So doxycycline, it's like the consultants say it's a magical bullet. The moment we start doxycycline, we see defervescence in the patient. So 200 milligram orally, followed by 100 milligram twice a day in adults until the patient improves or has been afebrile for 48 hours or has received treatment for at least 7 days, 5 to 7 days. So this is the treatment which should be given to the patient who is having ScrubTyphus fever. Then tetracyclines can cause tooth staining in children less than 8 years. So this is very important thing which should be kept in mind when we get a patient of ScrubTyphus like in PIC or an ICU. The Center for Disease Control Prevention advises that doxycycline can be given 2.2 milligram per kg orally or IV twice a day is warranted. And it is can be given for 5 days for mild illness and 10 days for high risk children. Research also says that short course that doxycycline can be given in children. So if doxycycline we want to avoid doxycycline, then the alternative is azithromycin, which can be given in children. Next slide, please. For pregnant women and patients with severe doxycycline allergy, the dose is azithromycin. So if we know if we are seeing that there is staining problem in the or if there is some kind of allergy, then we can switch to azithromycin 500 milligram on the first day, followed by 250 milligram daily for 2 to 4 or more days, or 1 gram initially, followed by 500 milligram once daily for 2 days. So azithromycin also a good alternative option. So later, the third option is chloramphenicol, that is 500 milligram orally, or IV 4 times a day for 7 days. So these are the 3 drugs which can be used in the patients who are suffering from ScrubTyphus, depending on the epidemiology of the patient. Next. Okay. So here this I have added what we should keep in mind. There are 2 very important things because I have just concentrated on 3 drugs: doxycycline, azithromycin, and chloramphenicol. But also there are rifampicin, doxycycline. There are many drugs which claim that yes, when we give for the treatment of the ScrubTyphus, they will help in the treatment of the disease. But here I would like to add upon DDs which is very important to keep in mind, and sending the test for the correct diagnosis is very important. So antibiotic, we shouldn't give blindly any antibiotic to the patient. So any antibiotic if we give, definitely it will go to give some useful result in the beginning. But if we continue giving antibiotic without testing, without knowing the actual cause of disease or the cause of fever in the patient, definitely it will give rise to antimicrobial resistance. So here we should keep in mind the antimicrobial stewardship. Though I have written just 2 words, antimicrobial stewardship, but it is again a full topic, and a full webinar can be done on antimicrobial stewardship. So we should keep in mind what are the drugs to be given, and we also have to take the help of the diagnostic stewardship. What do we mean by diagnostic stewardship? That we should take the help of the diagnostics which are available in the facility to start the antimicrobial. So diagnostic stewardship leads to antimicrobial stewardship, and together they will help in decreasing the antimicrobial resistance, which is a menace in the current scenario. Next slide, please. Okay, so coming to the disease burden in India. So we should know why we are discussing this, why we have taken this ScrubTyphus today, why we all are here to discuss this ScrubTyphus infection. So this was in some newspaper where it says that over 10 kids hospitalized, and Mamata Banerjee's big step amid spread of disease. So this was published in July 7, 2022. So this was there in the newspaper recently. And next, Kerala reports second death due to ScrubTyphus. So about the disease and symptoms. So this was again in June. 12th June 2022. This was again the news18.com. So this is the burden, and recently we are seeing a lot of cases from Kerala, from Bihar, so Calcutta. So everywhere we are seeing a lot of cases, and that is why we are here. How to diagnose it, how to treat it, and how to take a case of fever in the emergency department. Next. Okay, so this is again same. We can go to next slide. Okay, so here I wanted to discuss about the ScrubTyphus. This was a paper which was published from our hospital, and it was ScrubTyphus, a neglected tropical disease, a potential threat in North India. Next, in this, what we have done, we had taken the patients, all the patients who came to our emergency department who were suffering from fever, and we had studied, like we initially ordered the test for leptospirosis, for dengue, for malaria, for ScrubTyphus, and for hepatitis. So these were the tests which were ordered. Next slide. Okay. So then we concentrated only to the ScrubTyphus. So total of 34 cases which we got out of 134. Next. And here we see in our, like what we had seen, the peak was more in winter months, though the literature says that the peak is generally in rainy season. But what we have seen in my hospital, that in November, December, the cases were more. And there are many literature which say that during the winter months, the cases have increased. Next. So 34 serum samples were collected, and we tested for typhoid, dengue, malaria, hepatitis, leptospirosis, ScrubTyphus, and for ScrubTyphus, the ELISA system for IgG, antibodies we tested. And initially, what we did with a card test, and generally we say that card is not very specific and sensitive. So we also cross-checked with the ELISA; they all correlated well. But there were cases where we found co-infection, like in 2 cases, they were also having malaria, 4 were having typhoid, 17 were dengue test positive, and 3 were positive for leptospirosis. Next. Okay, so now previously I discussed the paper which I published from Sahara Hospital, and these are the real-time cases which I would like to discuss with you. There are few cases which was ScrubTyphus positive. So coming to the case 1, a 61-year-old male admitted to our hospital with fever for 1 month off and on, and for 1 week he was having high-grade fever. He had history of decreased appetite, vomiting, decreased urine output, difficulty in walking for 1 month, and he was referred from Gorakhpur, where he was admitted in a hospital for 25 days. Next. Okay, he had history of BD. Next. On examination, the GCS was very low, E2V1 M4. He was distributed to time, place, person. Reps were present. Abdomen was tender. BP was 140/90 millimeter of Hg, 98% SpO2, and he was on oxygen support. Temperature was 103 Fahrenheit. All the routine investigation was sent. Next. So the CBC, which I said that CBC is the first and foremost for any patient to send a complete blood count. It gives a lot of information. Here we see that the TLC was very high, 18.01. And here we see that eosinophil is 0.0. Generally, when the patient or when the body is in stress, is in sepsis, then we see this kind of picture, and the neutrophils are very high. So pointing that yes, there is infection. Next. Okay, so the liver function test, the alkaline phosphatase, SGOT, LCPT, they all were raised. Next. Okay, so PCT was 2.86, CRP that is raised. Generally, the PCT should be less than 0.5. It is raised. CRP 59.2. Sorry. The kidney function test was normal. Dengue was negative. Urine routine microscopy was negative. No abnormality detected. Blood culture, urine culture showed no growth, but the scrub ELISA test was positive. So routine investigation, we sent all the investigations where we found that the patient was ELISA positive. Next slide, please. Okay, so initially, the diagnosis of sepsis with right upper lobe consolidation was made at the time of admission, and the patient was started with meropenem and clindamycin initially. Then when the report came, the doxycycline was added, and the patient was in sepsis, was on SpO2 was 98% on oxygen support, and PCT also was 2.86. So they continued meropenem and clindamycin. Then a follow-up testing was done on day 3, which showed PCT decreased 0.8, TLC 13.51, and CRP 26. On day 10, the CRP was 11 and PCT 0.15. So this is how we should be monitoring a case of fever with sepsis with CRP, PCT, and CBC or TLC. So these are the 3 parameters which are very important when we are giving any antibiotic, and to monitor whether actually the antibiotic is acting on the patient or not. Next. So this is the last day complete blood count. Now this was okay. The TLC was 8.87 on day 10. Next. Patient condition improved, urine output maintained. Patient was discharged successfully, and he was reported to our OPD on day 10 after discharge, and he was perfectly fine. Next. Okay. So again, I'm presenting another case which was admitted to our hospital. Here, a 48-year-old male. He was admitted with high-grade fever, with chills, headache, nausea, 5 days back. And the patient was a known case of diabetes mellitus and hypertension. Patient here again complained of decreased appetite. On examination, BP was 150/90. And here the patient SpO2 was 97%, and he was on room air, no oxygen support. All routine testing like CBC, the viral markers, the ScrubTyphus, Leptospira dengue, urine routine, microscopic, blood culture, urine culture, typhoid, everything was done. ECG, chest X-ray, CRP, PCT, CBC, they all were initially done at the time of admission, and empirically injection ceftriaxone was given. Next. So on admission, the patients, the investigation which were sent, the PCT was normal, CBC was also very normal, CRP 45, LFT was little deranged, KFT was within normal limit, typhoid, leptospira, dengue, MP blood, I mean, they were all non-significant. Next. Okay. So this was the one test which came out to be positive, and then the patient was started with doxycycline. Next. Okay. So doxycycline was added, patient improved, and patient was discharged on day 8. Okay. So this is a third case. I just took this case because this patient presented to our emergency department with altered sensorium, and he had some signs of meningoencephalitis. Though this patient was discharged against medical advice, and I mean left against medical advice, so I didn't get the much history. But I would just this I have just taken to tell that even with the meningoencephalitis, vomiting, nausea, vertigo, altered sensorium, the patient was admitted. He was a known case of hypertension with arthritis. CCS was low, ABP was high, and temperature was 99 degrees centigrade. And the TLC was very high, platelet was 25,000 only. Eosinophils again here it was 0, which shows that the patient body was in stress. LFT, KFT, they all were deranged, and here again dengue, malarial parasite, leptospira cultures, they were negative, but ScrubTyphus was positive. Hepatic encephalopathy with ScrubTyphus was the diagnosis which was made for this patient, but since this patient GCS was very low and the patient was very septic, and we started with a meropenem, vancomycin, and doxycycline was later added, but we could not follow this patient as he left, I think, within a day or two. Just to show that, yes, with the neurological symptoms also, the patients were admitted to our hospital during that period. So coming to the counseling and education, suppose we know that the area is very much endemic to rickettsiosis, especially the ScrubTyphus. So what we can do, minimize exposure, avoidance of mild-human contact, and be aware of peak exposure times, that is the rainy season, the area, the moisture area that is very associated with the ScrubTyphus infection, where the places are with insects and arthropods. There we need to minimize exposure. Next. Okay. So what we can do, wear appropriate protective clothing, perform daily self-examination, shower, bathe after coming indoors, handle local and mirror, remove ticks. So many times there in the endemic areas, there are people, they will remove the ticks if they themselves, they see their body, so they find ticks in those areas, and they just need to see themselves in the mirror and remove the ticks. Next. So these are the areas which we need to inspect. So like hair, ears, inside the belly button, between the legs. So these are the areas where generally the these sugars get attached themselves, and then this is how they infect the human beings. So these are the areas which are very important. Next. Okay, tick removal. I just took the slide. So if the area, if somebody who has joined the endemic area, so they need to see how to remove the tick, how to hold them with the help of tweezers and remove them. So there's the photographs which show that how to remove them and put them in alcohol and put in a sealed back container and flush it down the toilet. Next. So what are the preventions coming to the repellent, use of DEET or permethrin, picaridin? So these are the various repellents which can be used to prevent themselves. Chemoprophylaxis only for non-immune individuals. So prophylaxis is not to be given to everyone, but it is only allowed for non-immune individuals. Weekly once 200 milligram doxycycline can be given. No vaccine is available till date to protect prophylactically. Next. Okay, so coming to the take-home message. So we should, or we must be able to differentiate. We should take proper history, whether it is fever more than 3 weeks or acute undifferentiated fever that is less than 3 weeks. Second, very important, which I have not discussed, we should be able to find out whether the fever is due to infective cause, which I just discussed, or non-infective cause, like the collagen vascular disease, the SLE, then there can be rheumatoid arthritis, or there can be some malignancy, neoplasm. They are also sometimes associated with neoplasm. So DD is very important, where we should also add to the echo in a patient. The infective endocarditis is also very important. So the echo can help to rule out infective endocarditis. Then we can also perform a lumbar puncture to find out the CF step picture. So these infective versus non-infective is very important to keep in mind. Then the differential diagnosis, once we know that it is infective fever, then the DDs should be in mind, like what are the infections, bacterial, virus, parasitic can be there. Then what are the tests which we need to send to confirm or to reach to our diagnosis. And once we have diagnosed it, we should know what should be the treatment plan. That antimicrobial stewardship again here plays a very important role. That yes, what are the antibiotics we should be giving? So if it is scrub typhus, definitely doxycycline will come into picture. Whereas if we don't have, if we don't get the scrub typhus as a diagnosis, then definitely we need to find out the other causes and the antibiotics which should be given to the patient. So this is, I think that's all. And here, one more thing I would like to add, like after COVID, in COVID, what we have seen that COVID has the COVID infection, post-COVID, we are seeing so many infections, they are coming up. And scrub typhus, if we go into the pathogenesis of scrub typhus, then it is like the T cells and the NK cells which are responsible for combating this infection. And also we know that T cells are there in, if the patient is having COVID-19, then there is little depletion of these T cells or the NK cells. So what, my just thought when I was preparing for this seminar, that if the patient is having COVID-19, and since this is scrub typhus is T cell dependent, so if the T cell is less than, like the chances of getting these kind of T cell mediated infections are more. I just thought, and I just thought to share it in this seminar. That's all from my side.
Thank you very much, Dr. Siddiqui. That was, how do I put it, exhaustive, and in terms of coverage from 0 to 100, you've covered the entire, spectrum when it comes to talking about whether it's fevers or scrub typhus. As a medical practitioner, this was a question that came to me when I was listening to you present on your slides. At what point do you, because the symptoms that present themselves for scrub typhus, there is no one definite symptom. I mean, there are the SRs, but other than that, there are a whole host of symptoms that can provide a road towards scrub typhus. So when you are looking at a particular patient, you took us through 3 case studies. What is it that you look for? What are the key symptoms that you would look for? Because you need to convince the patient, you need to convince yourself that this is scrub typhus. So before you prescribe a scrub typhus test, what are those things that you look for as a medical practitioner?
Okay, so first and foremost, what I would like to say, the 2 cases which I presented, they were having history of fever. So fever is very diagnostic. Fever, we have to keep scrub typhus in DD. Then secondly, HR and all, HR we didn't see. I think only one patient I had seen HR, because many a times when the clinicians, they'll they will order a battery of tests, like we have that, like dengue. Nowadays, this is the peak season. This is the season when we will get typhoid, we'll get dengue, leptospirosis and stuff. So in this season, generally, we before like starting, we need to send the battery of tests, as I have shown in my cases also. Initially, they started with meropenem and clindamycin. Then in second case, it was only ceftriaxone. But when they sent the test and it was ScrubTyphus positive, and it was initially it was difficult to convince also to the treating physician that it is ScrubTyphus, because they'll be like, how come it's here in the urban area. Then secondly, like it's very important, the splenomegaly, then the ranged LFT, the hepatomegaly, and these are the things which we have to find in the patient. So many a times, what in our hospital, generally we have a battery of tests which we'll send, and the test will come within 4 to 5 hours. So generally there will not be time lapse in the in sending the samples and in getting the results. So the antibiotics are added immediately. So, but what I would want, many times I have called my physician, sir, it is coming ScrubTyphus positive. Is there any SHAR present? Many times the medical officers or the doctors on duty, they'll be present. I call them up, just see just the patient for the SHAR. If not SHAR, then lymphadenopathy. Please just find out the lymphadenopathy. If not, then hepatosplenomegaly. So these are the three things which I would ask my duty doctors or my consultants to just please find out. And many a times they have searched, but because in India, maybe because of dark skin or patient, or we have once or twice that the consultant, they they call me back, and yes, they have found an HR in the patient's body. So, but very less number of times it had happened. But most of the time it's like the ScrubTyphus and the hepatosplenomegaly, which is like which we have found in our.
I traveled across the length and breadth of the country, and I have interacted with medical practitioners all over. So the first response that I get from respected doctors is that, Mr. Mahajan, there is no ScrubTyphus here. You know, that's the standard line as I get it. You know, there are no, I don't get cases. These are the biggest hospitals, the smallest hospitals, wherever, right?
Yeah.
Doctors who are ready to accept that ScrubTyphus exists. It's a hidden disease, you know, and like you said, that there is a lot of investigation that goes into actually confirming the presence of ScrubTyphus. So I want you to give a message today. It's not about JMitra. It's not about a product. It's about the fact that there is a disease out there. So what would be your message for the doctors? Because this video is going to go on YouTube, ma'am. So we would like to share it and let the doctors see that there is ScrubTyphus. So any message for the medical?
Yeah. So to this, even I would like to add. Initially, when I started doing ScrubTyphus, when I started performing ScrubTyphus testing at our lab, then they were like, "Have you confirmed it, or have you tested it? How come?" And like that, even I had challenge of convincing them that yes, it was ScrubTyphus positive. Many doctors, they will come to me and, yeah, you have given ScrubTyphus. I don't believe it, but I have started doxycycline and the patient responded well. So if the patient is responding to doxycycline, and if the ScrubTyphus is also positive, then definitely it is ScrubTyphus. And it's not the rural area where we are getting ScrubTyphus. It is because of urbanization, deforestation, and even the lawns and the kitchen gardens, the parks, they are all having the mites, the chiggers, which is responsible for this infection and human beings, since we are interfering in their ecological triad. So we are also now becoming a part of that disease, and it is there. And I would request all the people who are listening to it that they should keep ScrubTyphus in their DDs, If not, if they do not want to send tests, then definitely they should search for the HR, they should search for hepatomegaly, splenomegaly, lymphadenopathies, regional lymphadenopathies, pathognomonic, sorry, for this strep typhus infection. But at the same time, I will also request them to send the test for strep typhus too. If they are sending it for typhoid, if they're sending it for dengue or malaria. So these are the three tests which are very commonly sent. Whereas leptospirosis, the strep typhus, they take a back seat. Even hepatitis A and E, they also represent, but those tests are also not sent immediately. But what I would suggest that they should add strep typhus and leptospirosis typhoid, I mean, in the battery of testing which they are sending, and the complete blood count, that is also very important. PCT, CRP, and the leukocyte count, definitely they are going to help us in the antibiotic de-escalation. So these are the tests which they need to send. And they should get an idea like what is the prevalence of scrub typhus in their hospital. And if they get some features like ultrasonography or chest x-ray, many times the patient will land up into the respiratory department and the patient will be having only ARDS. Then yes, they have to keep this in mind. ARDS with fever, they have to keep this scrub typhus as a DD, and especially when the peak season is there, or when we know that it is endemic, then definitely we need to send this test.
Right. Thank you very much, ma'am. I think that last message is where we would like to close for the day. It's a very important topic that you've taken up when you talk about scrub typhus, because everybody can talk about dengue, malaria, right? It's something that's there in the forefront, but not too many people are willing to go out on a limb and talk about scrub typhus. So thank you very much. We are still living in the digital age and in terms of the pandemic. And so while we will have Govind and his team, somebody will be meeting you soon to deliver the certificate in person. But please accept our heartfelt appreciation and thanks for gracing us with your presence and this lovely presentation. Thank you, ma'am. Thank you very much. Thank you. Thank you, everybody, for joining us today on this webinar. Govind, thank you very much for being here. We will be having our next webinar on the 28th, which is a discussion on wheat-related disorders and diabetes. Thank you very much. Have a good day. Jai Hind.
Thank you.